Chapter 17, Somatic Symptom Disorders. So somatization is when emotional distress and psychological issues are exhibited in physical manifestations that cannot be explained medically. These clinical manifestations are real and they can include pain, GI issues, and sexual difficulties. These disorders can be just as debilitating as a physical disorder, and the patient may begin to feel hopeless and helpless. But remember, some serious medical complications may be worsened by emotional stress. Some examples would be cancer, hypertension, immune disorders, and cardiovascular disease. There are some cultural considerations. The type and frequency of somatic symptoms vary across cultures. In some cultures, certain physical symptoms are believed to be the results of a spell that has been cast. In the U.S. immigrant population, primary care visits are often due to response to a traumatic event. So the primary disorders we're going to talk about are somatic symptom disorders, illness anxiety disorder, conversion disorder, cognitive factors that affect medical conditions, and then there's two that are under conscious control we will talk about, and that's factitious disorders and malingering. So let's talk first about somatic symptom disorders. These patients focus on the physical symptoms to a degree that causes major distress and or problems with their everyday functioning. The clinical manifestations, they may have one or more distressing symptoms, with pain being the main symptom. Other symptoms are vague, with chest pain, abdominal pain, fatigue, dizziness, headache, and back pain being the most common. The patient will exhibit excessive thoughts, anxiety, and behaviors around the symptoms without significant physical findings or diagnosis. However, their suffering is authentic. They have difficulty accepting concerns over symptoms are excessive, and they continue to be fearful and worried, even though there is no evidence to suggest a serious medical condition. Most patients seek care from their primary care physician rather than a psychiatrist or mental health professional, and they may actually be resistant to accepting psychiatric help because for them it is not, quote, all in their head. Now, etiology is difficult because patients do not seek treatment for the disorder itself, but there is about a 5 to 7% occurrence among adults, most beginning around the age of 30. Comorbidities, anxiety and major depressive disorders. Risk factors, biological. Genetics play a role, as well as neuroticism, which is a fundamental psychology trait that reflects a person's emotional stability. And then environmental is often precipitated by a stressful event in a person's life. So our guidelines for nursing care, you need a strong therapeutic relationship, provide education on their signs and symptoms, provide consistent reassurance, family support, encourage a healthy lifestyle, concentrate on current bodily symptoms initially, and focus on development of self-compassion, because self-compassion is often lacking. And these are some of those guidelines you need to read for nursing care. Be aware also of maladaptive coping strategies and placing blame. These patients will place blame. They'll say things like, well, my blood pressure would go down, but my boss won't buy me a gym membership, because they need some type of explanation for their symptoms. Treatment modalities: offer support, avoid unnecessary or repetitive diagnostic tests. They may need hypnotherapy, and they may need CBT therapy in conjunction with medication. And medication options usually include SSRIs and tricyclic antidepressants. Illness anxiety disorder is also known as hypochondria. The clinical manifestations: the patient has a fear and a preoccupation with having or acquiring a serious illness for at least 6 months. The actual somatic symptoms will be absent or mild. There is frequent self-scanning for signs of illness. They may be care-seeking or they can be care-avoidant. Social media and loneliness can increase fears. And there is a UCLA loneliness scale on page, UCLA loneliness scale on page 317. Epidemiology, about 1.3 to 10% of the 1.3 to 10% prevalence with males and females being equally affected. Comorbidities with illness anxiety disorder include anxiety and personality disorders. So some of our risk factors. Environmental is usually precipitated by a stressful life event or a health threat with a positive result. And your ACEs can also be a high risk factor. Cognitive, the patient may view symptoms as punishment, and the patient may also display aggression, anger, or hostility related to past losses and disappointments. And if the patient has low self-esteem, this may be a defense mechanism. Treatment modalities, pharmacotherapy to treat the actual symptoms, as well as SSRIs to treat anxiety. Also, ECT, CBT, and ICBT. ICBT is a digital platform, such as an app that helps patients identify and reappraise their negative thoughts. And then guidelines for nursing care. You can see here. Okay, conversion disorder. The clinical manifestations, the patient will exhibit neurological symptoms such as seizures, weakness or paralysis, or reduced input from senses without an actual neurological diagnosis. They have anxiety that is relieved through their physical symptoms. There is a term here called label indifférence. It is the absence of psychological distress despite having a serious medical condition. Basically, there is a lack of emotion about the dramatic symptoms, so they may blow off their symptoms. Epidemiology, there is a low rate of prevalence, but it is 3 times more common in females. Comorbidities will be major depressive disorder and dissociative disorder. Risk factors, biological and physiological. Anyone with a pre-existing neurological condition is at an increased risk. Neurobiological, they may have a biological basis in hypometabolism and cortisol release. Environmental, psychological and traumatic events, as well as family dysfunction. And cognitive, it is viewed as a way to avoid or cover up unwanted feelings. You can see your guidelines for nursing care on page 318. And I just want to go back up to that clinical manifestations for a moment. I said the patient exhibits neurological symptoms such as seizures, weakness, paralysis, or reduced input from senses without an actual neurological diagnosis. Another way to look at it is these patients may involuntarily lose their vision or their ability to hear, but they're not worried about it. So that's that conversion disorder. You've got this stuff going on, you have symptoms, but you're not real worried about it. Treatment modalities. In severe cases, they may require an aggressive approach, such as with narcoanalysis, which is the use of barbiturate steering therapy, and they may need hypnosis. You have body-oriented psychological therapy, which provides unity between the mind and the body to provide a link to change. DBT we've talked about, but this is a type of modified CBT therapy in which the patient focuses on living in the moment and developing healthy coping mechanisms. Psychodrama is a type of role-playing to help the patient gain insight into their lives and experiences. And then physical therapy can be used to improve motor function. cognitive factors affecting the medical condition. Cognitive factors may increase the risk for medical disease, magnify them, or interfere with their treatments. Examples include depression and the increased risk for developing cardiovascular disease and cancer. Stress can also cause medical conditions, as I mentioned in the beginning. On page 319, there's this table 17.1 that are common medical conditions negatively affected by stress. Epidemiology, it seems to be very common, but there's no specific data for this. Risk factors. Negative health outcomes are associated with loneliness and lack of interpersonal relationships, but there's something here called resilient coping. And this is the ability of people to maintain relatively stable and healthy levels of psychological and physical functioning when confronted with a highly disruptive situation. Your guidelines for nursing care are here on page 320 under the bullets. And as far as your treatment, this includes treating the anxiety, depression, and the loneliness. Okay, assessment. So now we're going to discuss the steps of the nursing process related to somatic symptom disorders. On page 321, here's an example of a questionnaire about somatic symptoms. So assessment guidelines. You see your box here on 320, numbers 1 through 8. Please review those. Medical history. You need to look at any underlying condition that may cause symptoms. Then you got your psychological factors that are here on table 17.2 on page 322. Please review. Nutrition, fluid balance, and elimination needs. Patients often have complaints of GI distress, so you've really got to look at this. Coping skills. They have on present, or they can at least develop positive coping skills, because often they are able to communicate their emotional needs if you work with them. Spirituality and religion, because as we've already talked about, faith promotes resilience. Communication, ease with verbalization of physical symptoms, but they may have difficulty talking about feelings or emotions. And then self-assessment, feelings of anger, resentment, and frustration can occur. Nursing diagnoses, difficulty coping, anxiety, risk for loneliness, powerlessness and hopelessness, chronic low self-esteem, impaired socialization, pain, impaired family process, and risk for suicide. Difficulty coping is the priority diagnosis here. Outcomes, there should be shared decision making, the patients should participate, outcome criteria needs to be realistic and attainable, and do this in small steps or even in increments so that they can see concrete evidence of their progress. And you can see some more on this in page 7, table 17.3. One of the biggest outcomes you want to see here is that they can demonstrate performance of their former roles and their tasks within their own families. Implementation. Most of the long-term psychosocial care will occur on an outpatient basis, so the goal is stabilization. You need to establish an integrated model of care, a therapeutic relationship, and foundation for patient education. Establishing a trusting relationship is crucial because many patients will go from doctor to doctor seeking treatment. Psychosocial support, this includes coping skills, support groups, focusing on strengths, reinforcing skills, and promoting self-care activities. They may need assertiveness training, which is used to help people learn how to better communicate their needs and wants so that they do not feel taken advantage of. Case management. Since these patients tend to doctor hop, case management may be helpful to avoid unnecessary labs and diagnostics. And you also can see table 17.4 for some interventions. And just remember, it is important to explain the pathophysiology of the symptoms to these patients with somatic symptom disorders. And we want to shift the focus from the somatic symptoms to feelings or neutral topics. This conveys interest in the patient as a person rather than in their condition. There are 6 key elements for effective treatment. You need to provide continuity of care, avoid those unnecessary procedures, provide frequent, brief, and regular visits, always conduct a physical exam, avoid disparaging comments, and set reasonable therapeutic goals. And their evaluation, it should be based on clear, realistic, and measurable outcomes. Goals are often reported as only being partially met. And for the patients, they often do report continuing somatic symptoms, but they often report less concern about them. Treatment modalities, again, cognitive behavioral therapy, and then coping strategies that preclude somatization, because we want to do these strategies, coping strategies, to reduce anxiety to a tolerable level for them. So Mr. Brazali is brought to the emergency department by a cab driver who walks with him into the entrance and says, "This guy says he just lost his sight. He just went blind right after he got into my cab." Mr. Brazali is very patient and says during assessment, "Well, I've had several episodes like this. I guess this just happens sometimes." During assessment, Mr. Brazali says that when these episodes of blindness come over him, it is often immediately after an epileptic fit. Testing, however, shows no signs of recent seizure. The ED physician records that Mr. Brazali has a neurological symptom, but in the absence of a neurological diagnosis. He also makes note of this patient's lack of distress about what should be an alarming condition. Which diagnosis describes Mr. Brazali's condition? D. Conversion disorder. And what is this called, this indifference? Label indifférence. Okay, a factitious disorder. So this is different from other somatic disorders because it is under conscious control. This was previously known as Munchausen syndrome or Munchausen by proxy. This person deliberately produces symptoms of an illness for the purpose of receiving care and attention, not with practical benefits, but for psychological gain. The person craves the attention and the excitement. It can be imposed on self or on others, in which the individual imposes an illness on a vulnerable dependent for the purpose of seeming like the hero. The patient or victim may go through extensive, painful, and unnecessary diagnostic tests and surgeries. So epidemiology, there is a low incidence, more than likely due to misdiagnosis or denial by the patient. Comorbidities, physical problems, as well as substance use, personality disorders, and sexual disorders. Risk factors, biologically, it may possibly be caused by impaired information processing in the brain, but there's no evidence to suggest genetics for this one. Cognitive, these people may have suffered abuse and or neglect in childhood or had an illness that required frequent hospitalizations. There is also evidence to suggest a masochistic side in which the patient feels they need to be punished by having all of the unnecessary testing. Nursing care, be aware of your own feelings as the nurse because anger and resentment can surface, but safety even for you is the priority. And then treatment modalities, CBT that focuses on childhood trauma is the most effective treatment for factitious disorder. In malingering, this is a condition related to factitious disorder, so it is voluntary. It is a conscious fabrication of illness or exaggerating symptoms for secondary gain, such as insurance fraud, prescription medication, avoidance of prison or military service. Which problem does not fit in this group? A. Malingering, because it is related to a factitious disorder that the person has conscious control of. Which is an example of an illness anxiety disorder? D. Mr. Moonani frequently calls or comes to the clinic in a panic, believing she is ill. Her suffering is genuine, but she never has a concrete sign of illness. A would be considered malingering, B is a factitious disorder, and C is a somatic symptom disorder. You need to know how to differentiate between all of these.